Hi there, my name is Brian Todd. I am currently working as a clinical technologist in the photobiology department of Ninewells Hospital in Dundee. I will present our findings that will be published in a letter to the British Journal of Dermatology. This is also the same presentation that was given at the most recent Congress of the European Society for Photodynamic Therapy. Our work investigated the provision of variant doses for PDT treatment. PDT is widely used for the treatment of both Bowen's disease and superficial basal cell carcinoma. Bowen's disease affects the squamous cells in the outermost layers of the skin and is sometimes referred to as squamous cell carcinoma in situ. This is usually very slow growing, with a small chance that it could turn into a more serious type of skin cancer if left untreated. Superficial basal cell carcinoma is also known as a rodent ulcer. It starts in the cells lining the lower epidermis and accounts for approximately 75% of all skin cancers. The photographs here show a Bowen's disease lesion both before and following successful treatment. Both licensed prodrugs are shown here, with light activation being carried out with nanospectrum red light LEDs. The prodrug is applied topically to the skin and is converted via the heme biosynthetic pathway into the photosensitizer protoporphyrin 9, or PP9. Cancer cells either lack or have reduced pherochelatase activity, resulting in the accumulation of PP9 in these cells, in preference to the healthy cells surrounding them. The light activation of PP9 within the cells induces necrosis and apoptosis. Although PP9 preferentially absorbs blue light, centered around approximately 405 nanometers, there is also an absorption peak centered around approximately 630 nanometers. The use of red light in PDT for skin lesions is preferential, as it has been shown to penetrate further into the skin, approximately 6 mm versus 2 mm as for blue light. From 1998 until 2004, we used a tungsten filament source delivering a dose of 75 joules per square centimetre. In 2004, we changed to an LED source delivering a dose of 37 joules per square centimetre. We observed lower efficacy with LED doses of 37 joules per square centimetre when compared to the results we had seen previously with the tungsten source at a dose of 75 joules per square centimetre, and reverted to an LED dose of 75. We believe that the rationale for change was theoretical and based on spectral output and relative weighting of irradiance of these light sources. To our knowledge, there have been no studies comparing the efficacy of the different LED light sources used during PDT for Bowen's disease and basal cell carcinoma, although studies have been carried out with actinic keratosis. Are the PDT outcomes for Bowen's disease and BCC influenced by light dose? It would be more efficient to use a lower light dose if efficacy was similar. Shorter treatment times would allow us to treat more patients in the same time. There is also some limited evidence that shorter treatment times are more comfortable for the patient, although shortening the time of the usually uncomfortable treatment would be advantageous. However, regardless of any other factors, we should strive to offer the most effective treatment that we can. In other words, that which brings about the greatest likelihood of lesion clearance. Our goal here was to compare the outcomes of two PDT regimens and investigate the effects of light dose on treatment efficacy. Our study was prospective and carried out over 1 year. Patients that were referred for PDT for either Bowen's disease or BCC were alternatively allocated treatments using either 37 or 75 joules per square centimetre. Allocation was not based on sex, age, lesion type or location. We can see here that there is a skew to legs for 37 joules per square centimetre treatments and back for 75. This will be covered later in the presentation. Lesions were treated on a total of 38 patients. 62 lesions were treated in total. 18 patients were treated with 37 joules per square centimetre, between 1 and 5 lesions per patient, a mean of 1.7, and 20 patients were treated with 75 joules per square centimetre, between 1 and 9 lesions per patient, for a mean of 1.6. The review and retreatment as necessary schedule used throughout the study followed our standard practice. The initial review was carried out 3 months following the first treatment cycle, a treatment cycle consisting of 2 treatments over a 2-week period. Repeat treatments were carried out following 3-month reviews if there was still evidence of lesional cells. Repeat treatment cycles used the same prodrug and light dose as the initial treatment cycle. Final review was carried out at 12 months following the initial treatment cycle. It must be noted that the data used for this study was only from patients that attended all required treatments and reviews up to 12 months. At 3 months, the outcomes were as follows. Similar outcomes were achieved after the first PDT cycle. 64.5% lesion clearance was seen in the 37 joule per square centimetre treatment group, with 67.7% lesion clearance seen in the group treated with 75 joules per square centimetre. Therefore, similar proportions of each group, 33.5% and 32.3% respectively, received a repeat treatment cycle. The 12-month outcomes, however, showed a most striking difference. Clearance was seen to be 67.7% for those treated with 37 joules per square centimetre, but a much higher 90.3% on those treated with 75 joules per square centimetre. It must be noted that second treatments followed the initial regime for that patient. For example, 37 joules per square centimetre patients were treated with 37 joules per square centimetre, and 75 joules per square centimetre patients were again treated with 75 joules per square centimetre. The proportion of lesions requiring a second treatment cycle was very similar between the 2 regimes. However, following second treatment cycles, the 12-month outcome is notably better for those lesions treated with 75 joules. This indicates that the 75 joule treatment is more effective, especially when a second treatment cycle is required. Note that there is a very clear difference in the response at 12 months following a second cycle of treatment. There is a drop-off in clear lesions treated with 37, but no change in those treated with 75. We have shown improved outcomes at 1-year follow-up for PDT for Bowen's disease and BCC lesions when using a higher dose of 75 joules of 630 nanometer red LED light than when using the lower dose of 37 joules as is currently recommended. The proportion of lesions requiring a second treatment cycle was very similar between the 2 regimes, and the difference that we have seen is most evident for lesions requiring a second treatment cycle. However, following the second treatment cycles, the 12-month outcome is notably better for those lesions treated with 75 joules, indicating that the 75 joule treatment is more efficient, especially when a second treatment cycle is required. We are not aware of a specific rationale for the use of a dose of 37 joules per square centimetre when using narrow spectrum red LED light in PDT. Mathematical modelling has shown that LEDs are more effective than broadband light for skin penetration to depths of greater than 1.5 millimeters. However, this modelling was carried out in mouse skin, and it was also shown that the fluence required by the broadband source was 1.3 times higher than that of the LED source to produce 90% PP9 bleaching. Monte Carlo simulations indicate that at a 2 mm depth, the photodynamic dose for the red LED source is more than twice that of a broadband lamp. These simulations also demonstrate that effective treatment depth is increased at higher light dose, with singlet oxygen production still occurring at depth even after surface layer photobleaching. There is some evidence that red LED should be more efficient for treatments than the incandescent sources used previously. However, the work referenced here is not based on data from human studies, being either animal or simulated studies, and therefore does not give a complete rationale for the change to a lower light dose when using LEDs. Irradiation at 75 joules per square centimetre during PDT for Bowen's disease and BCC was associated with notably higher clearance rates at 12 months than when using 37 joules per square centimetre. This was most marked for lesions treated with 2 treatment cycles. These data indicate that higher irradiation doses may be more effective, although further prospective studies are required to determine the optimum dose requirement during PDT. Currently, we are only able to observe that a dose of 75 joules yields the greater clearance than a dose of 37 joules. However, we do not know if 75 joules is the most effective dose. It could lie somewhere between 37 and 75 joules, or perhaps even beyond 75 joules. Although we have shown a marked difference between the two regimes, there are limitations to the study. A small patient cohort of only 38 patients, some patients exhibiting several lesions, up to 9 lesions in a single patient, and body sites were not factored into the study, with a skew towards the legs for the 37 joule cohort and to the back for the 75 joule cohort. It is possible that a larger multi-centre study could be very valuable for further investigation. Here we can see the references that were used for this investigation, and thank you for listening.